For those of you who don't know me, I'm Patty Harper. I am one of the principals at inQuiseek. I'm also on the board for the National Association of Rural Health Clinics, and I teach Medicare RHC billing across the country, and was one of the contributors for the billing information that is in the Certified Rural Health Clinic Professional certification that we'll hear about this afternoon. This is a great group. It's a small enough group that we can take questions, we can have discussion. So just like the other speakers have said, if you have a question, let's talk about it while we're on that slide and not hold it to the end. So this is just going to be a Medicare billing update. So it's not going to be our complete Medicare billing. That takes a lot longer. We're going to go over some simple reminders that still tend to cause us problems, and then we're going to go over some changes for 2022, some things that resulted in the finalized physician fee schedule rule that affect rural health clinics. And then we're going to kind of throw in just some extra stuff. So again, just ask questions, stop me. I know. So we always like to start with what is a rural health encounter, right? So that's what we get paid for. We get paid for services that fit in that rural health clinic encounter definition. And if we have new providers, we have new billing staff, we may not remember to tell them what an encounter is. It's a very important definition. And so it is a face-to-face encounter between a patient and one of our qualified RHC providers, whether that is a physician, MD, DO, nurse practitioner, physician assistant, certified nurse midwife, or licensed clinical social worker. So those are our qualified rural health clinic providers for Medicare. Your Medicaid provider list may vary from the Medicare list, and your definition of an encounter for Medicaid may slightly differ. So, we don't like to hear, oh, well, I hired a licensed professional counselor, which may, and I'm sorry, I don't know, which might be okay for a Medicaid program or a commercial plan, but they aren't a Medicare provider for an RHC. So we need to know those providers and those definitions. We have to have a medically necessary service. So we have to have that face-to-face between the provider and the patient, and it has to be medically necessary. So whatever that test is for medical necessity. We cannot call a patient back for normal lab results. We can't call a patient in for just a medication refill if we're not actually doing an evaluation and management service. So it has to be medically necessary. Also, typically it is a level 2 or higher evaluation and management service, or an approved procedure or service that is on our qualifying visit list, which we'll look at in a minute. That is a rural health clinic encounter. So that is reportable to Medicare, and it is payable by Medicare at our all-inclusive rate. So anything that we do that is reimbursed at our all-inclusive rate must be an RHC encounter. So, so that's a very important. We have the qualifying visit list. Are y'all familiar with this list? So it has not been, the print copy of it has not been updated since October of 2016, that's 6 years ago. But if you have any question about whether what you want to do is going to fit in that encounter box, then this is a good go-to place to look for. When it came out, they were transitioning some codes. Every code on the list now is a QVL code. These codes are updated quarterly through the Medicare OCE edits, but they have not updated the document. And so some of you may have known that about a year and a half ago, about 11 codes fell off of this list. And now we know to check the quarterly updates, and then we let NARC know, and they lobbied to get them back on the QVL list. So like earwax removal was taken off, IND was taken off. We got those put back on because those are valid reasons for an encounter. So now we know where to look, and several of us look every quarter to see. It's going to be your evaluation and management codes. It's basically going to be the things you would normally do in a medical office. Common office procedures, evaluation and management, and other medical services like our mental health services and things like that. But I didn't put the link here. If you can't find it, email me and we'll get you the link. Okay, now we're just going to go over a few little reminders. So we also have had the CG modifier for 6 years now. Does it seem like that long? April 1st, 2016 is when we first got the CG modifier, and we first had to start changing the way we formatted our claims. We still have problems with the CG modifier. So again, if you add new billing staff, if you go with a new billing company, it might be important to make sure everybody's up to speed on the CG modifier. Also, we still have problems with split billing. And so I wanted to kind of touch on a few of the things that are problematic about our split billing and talk about things that are not paid at our all-inclusive rate that are paid at a fee-for-service amount. So this is just there's a Q&A document on the CG modifier, so this is just basically talking about the CG modifier. It is from this document, which I also did not put the link on. But it will answer all of your questions. So it's a really good go-to place if you get a new biller, you get a new billing company. Billing companies will tell you that they understand rural health clinic billing, and they don't. So it's a good place to go for that. All right. So we must have one line on our Medicare UB claim that has the CG modifier. That CG modifier has to be appended to one of the codes that are on the qualifying visit list. And that CG line should be one of our main revenue codes in the 52X category. So our 521 is in the clinic, 522 is in the patient's home, 524 is Part A skilled nursing, 525 is a Part B skilled nursing, and we have that 528, which we never use, which is place of accident. All of the charges on our claims, we're going to look at this, are rolled up to the CG line, and I'm going to show you an example of that. This is still problematic, people getting their systems to do the roll-up correctly. And there's a reason why it's super important that that happens. We also can only have, in most cases, the CG modifier on one CPT HCPCS code on the claim. There is an exception to that. And so we do have problems where people have hard-coded the CG modifier into their fee schedule or their charge master, and we're ending up with more than one CG modifier on the claim. Some systems really struggle, and that CG modifier is having to be put manually on. How many people have it where their system automatically puts the CG on? And how many people have to put that manually? So it looks like everybody's having their system do that pretty well. Is it rolling up the charges correctly? Okay. More sophisticated systems will typically be able to write those logic rules for that. Some of our more simple systems, people are having to go in and edit in the patient account detail. I started as an accountant, not as a compliance person, and it makes me uncomfortable that we monkey with the with the account level detail to make the claim format. In a perfect world, we want those business rules to be displaying the claim correctly, but we want the patient account information and those charges to stay just as they crossed over. So some smaller systems have problems with that. The reason that it's important that everything rolls up correctly to the CG line is that is the only line that Medicare will process. Everything else is going to deny out. plus everything on the CG line is going to have deductible and co-insurance applied to it. So if we have something rolling up to that CG line that is a non-RH service like our labs, we're going to be overcharging our patient deductible and co-insurance amounts. So it's very important that we're making that roll up and we're doing the split billing correctly. The exception is if I have okay, so I got ahead of myself, which I'm so bad about. Okay, so here's a claim example where we have 99214 and we have an injection administration. So our office visit, and the prices on here are just mainly for easy math for me. They're not meant to imply that that's what your charges should be, because we can't do that. So 125 is going to be my office visit. 15 is going to be my admin fee, and 65 is going to be my Rocephin. All of those charges roll up to my CG line. And yet I still have to report the other line items with either the customary charge or a penny. Again, if you're reporting it at a penny, we want this to be something that's being done behind the scenes. We went in somewhere not too long ago and everybody had changed all of their charge master prices to a penny. So that's not what you want to do, not what you want to do. And so this is an example of how we would put the CG on the office visit. If you have more than one CPT HCPCS code that is on the QVL, more typically than not, the CG is going to go on the E&M code or the code that was the primary reason for the encounter. So here's what it looks like if we do that. And I think we can make these slides available to you after the conference, or you can email me and I'll send them to you. There are a couple of times, well, there's only really one time we will have two CGs on a claim. If we have a medical visit and a mental health visit on the same date of service, then we are going to have two CGs. Each service is going to pay our all-inclusive rate, our RHC rate. Nothing rolls up. Each line stays independently and separately reported. So this is the exception to two CG modifiers. If we have two medical visits in the same day, I don't have this example, but if we had two medical visits, we would not put a CG on both of them. We would put a CG on the first one and a 59 on the second one. So a caution there. I think I have a slide later. We don't use 25 and 59 on our Medicare claims as a general rule. It can overpay us. Okay. If I have an office visit and a welcome to Medicare exam, the CG is going to go on the office visit, like this slide shows, and the welcome to Medicare exam is going to go on a separate line. Nothing rolls up on this example, and both lines will pay the all-inclusive rate. The Welcome to Medicare IPPE exam is the only preventive service that will pay a separate AIR on the same date as a medical visit. If I were to do an annual wellness visit with a medical visit, I'm only getting paid one money. So, so that is something to be careful about. Anybody having trouble with wellness visits? Billing, getting paid for them? Okay. We've heard a lot about care management, but not so much about transitional care management. It reimburses at our all-inclusive rate. And there are two levels of transitional care management. Both of those are on our QVL list. So this is something we want to make sure that we're doing. Somebody talked this morning about making sure that you knew about your hospital discharges. So we want to make sure we're looping that patient back into the rural health clinic to make sure that we are getting them back into primary care after a discharge. So transitional care management. A lot of people are seeing those patients, but they're just assigning a regular E&M code and not the transitional care management codes. So I talked about we don't use 59 and 25. It will drive a coder crazy, but we can be overpaid if we use 59 and 25 on our Medicare UB claims. 59 we use for 2 separate unrelated medical visits. So what's an example of that? My patient is in the clinic in the morning for scheduled follow-up on their hypertension and their diabetes, and they go home in the afternoon. They're working in their garden, and they have an injury. They have a laceration. They have a sprained ankle. They come back up to our clinic to treat that injury. That is a second unrelated visit. And so we should be able to be paid 2 times for that. Now, what we cannot do is stage services. So if the patient came in the morning for their hypertension and diabetes and said, oh, by the way, I have this nasty mole on my arm, and we say, oh, great, come back this afternoon and we're gonna freeze that off for you or whatever. That does not qualify for this situation. We would schedule that patient on another day for that lesion removal. Any questions about that? Yes, ma'am.
What about a patient that comes into your clinic to see their provider, let's say for their blood pressure, but the next hour they have a visit scheduled with the specialty provider?
Oh, that's a great question. So the question is, what if I have specialists in my RHC and the patient has an appointment on the same day with the primary care and, say, the orthopedic? Great. 1 medical visit. Both of those visits count as a medical visit. We only have 1 medical visit per day. So that's really problematic for a number of reasons as we're trying to integrate specialists into our rural health clinics. We can have specialty care as long as it is 49% of what we do. So primary care still has to be 51%, the majority of what we do. We are in primary care, health care, professional shortage areas. So we are to be in the business of primary care. Mental health also counts as a specialty care, but we are paid for a medical and a mental health visit. We are not paid for a primary care and a specialty visit on the same day. Okay, each RHC will stand on its own because they should have different MPI numbers. Yes. Because that's not, each clinic is a certified facility in its own right. The problem we have with your scenario is that patient may have access to care issues, and we're trying to schedule all their appointments on the same day. But we also have problems with that because if we only get paid 1 rate, if our provider is compensated by work RVUs, who's getting credit for the work RVU? So that's another problem with that. I could give a whole nother talk on why I don't think your RHC providers should be solely RVU based for compensation, but that's a whole nother discussion. You want that discussion? Well, the long and the short of it is, no, but just the long and the short of it is we are not paid off the fee schedule. So why would we compensate our provider in a way that's not parallel with our reimbursement model? Now, it's fine to, commercial payer, and it depends on your payer mix. It does depend on your payer mix as to whether you want to do that. It's fine to have a productivity standard that's work RVU based, but I would not have it all work RVU based, and I would make sure that that work RVU also aligns with the productivity standards for the cost report.
Meaning 42, 2100 per FTE?
Not maybe exactly, because maybe that provider doesn't work, maybe they're not a full FTE.
Well, but on the provision equipment, so 4200 would be the FTE.
So 4,200 is the visits for a full-time equivalent based on the hours that that provider can see patients. So we never have a provider that is a full FTE.
I'm assuming that that equates to about 24 to 32 hours of actual patient time.
Yeah, I mean, I just like there to be some kind of check and balance, like kind of calculate it two different ways and make sure. We have seen clinics where the base work RVU was so low, was too low, and then the provider was being bonused, and yet they weren't meeting productivity standards.
All right, so are you familiar with any models then that have a productivity bonus based upon using the Medicare, the CMS per encounter
We do see some of those.
but applied to, also that applied to the commercial as a visit, but adjusted by checking the commercial rate to see if it is anywhere approaching that. In other words,
Yep.
adjusting that rate by the RVU.
Yeah, I can see that.
Okay.
Yeah, I can see that. I don't want somebody just to pull down MGMA productivity standards and just have a boilerplate agreement. I also like to see, this is not a compensation talk, but it's where it's going. I also like it, I like compensation to also be incentivized by adoption of technology, timely filing of notes, quality performance, medical staff citizenship, how well do we play in the sandbox with everybody. I like a more whole, complete model.
So, I don't know if you're familiar with CMS's proposed or draft model for the value-based, value care compensation, which basically says, here's some areas that you ought to check out and include in your value modeling.
I haven't actually seen that, no. No, I have not, no.
There's a draft out there.
I thank you, I would like to look at it.
Okay.
We
We're
just,
modeling that.
and it's working well for you?
We're just about to implement it and start running first data by quarter and testing it to see how well it works. Right now, our compensation model is incentivized to visits because in reality, the business is reimbursed on the per visits, but we do want other measures there as we prepare to transition to it.
Yeah, I like that idea. I just like a check and balance in there. You know, we still see a lot of places rolling out boilerplate compensation agreements based on RVU amounts that were 20 years ago. You know, their attorney gave them a compensation agreement 20 years ago and they haven't looked twice at it. And you know, it also depends on your payer mix, how much Medicare, Medicaid you have, whether, you know, if you're high commercial, then you know, that work RVU is going to mean something different to you than if you're primarily Medicare, Medicaid. So, so yeah, those are great discussions.
Okay.
I'd like to hear how that's going for you. We'll let you know. Great. Okay, so back to the CG modifier. I love that we just had this discussion. So when do I not use the CG modifier? So with COVID and telehealth and all of these other things we get paid. If you watch social media, it's like we get 100 questions. Do I put the CG modifier on it? Do I not? When do I not use the CG modifier? Our current guidance is it does not go on our Medicare telehealth visits. At the very first, in April of 2020, the CG modifier did go on there. It paid our rate, because anytime we have the CG modifier, it pays our rate, and then what happened? They took that difference back. So it does not go on telehealth. It doesn't go on virtual communication services or on any of our care management claims. So telehealth, virtual communication, and care management, whether it's chronic or principal, do not pay at our rate. They pay at a blended consolidated fee schedule amount. And so anything that doesn't pay our rate never has the CG modifier on it, because the CG modifier, I'm in a state that has casinos. They haven't done for our state what they were supposed to do, fund education. They haven't done that. But we still have them. So I call the CG modifier the pay line. It's that pay line on the slot machine. If we want to get paid for an encounter, get paid our rate, we've got to have a CG line. That's our pay line. So if we're not getting paid our rate, we're getting a fee schedule amount for distant site telehealth, for care management. The CG does not belong on that claim. And so we still see people, maybe they have new billers and they haven't gone over that. So anything that does not pay our rate does not get the CG modifier on it. Okay. Let me see what I'm forgetting. Also, the CG modifier is a special government modifier for rural health clinics. It does not go on commercial claims, and it doesn't go on a Medicare Advantage claim unless that payer has asked you to use it. So some of our Medicare Advantage plans will follow Medicare rules strictly, some will not. So you'll also get a denial on a commercial plan if you use the CG modifier incorrectly on that claim. Okay. Any questions about the CG modifier? Any other problems that anybody has had? This is our 6th year of doing the CG modifier. It still gives us heartburn, right? So, okay. We talked a little bit.
Medical protocol, if you're still having heartburn with the treatment after 6 years, you should just continue.
That's great. Preventive services, we kind of touched on preventive services when we talked about care management and quality this morning in the other sessions. The link at the top of this slide is a guide for RHCs for preventive services. Almost every preventive service, when performed alone, pays the AIR. And so sometimes I think our providers need a little education on this, because I think maybe they're doing things that could be another separately reimbursable encounter. I'm not advocating that we string that patient along and we bring them back 6 times. I'm not suggesting that. But if your provider doesn't have time to fully address that issue, a lot of these preventive services will qualify for a second visit and pay at the rate. And so I find that mainly to be a provider education. The providers just don't know about which things they can be separately paid for.
What I hear you saying is that care would be improved if the visit was scheduled solely for the purpose of focusing on the annual wellness, giving it opportunity.
So that's true. So we don't get paid. So if we did the annual wellness visits, for an example, the depression screening is optional for the annual wellness visit. The depression screening on its own pays another separate AIR. So if later in the year the provider felt like that patient needed to have a full depression screening again, that is a separate AIR. Tobacco cessation pays a separate AIR. So if that provider feels scrunched on time to go over everything that needs to be covered for a successful tobacco cessation program, then that could be a whole visit by itself. And so there's a chart. If you go to that link, you're going to see this chart, and it's going to tell you the HCPCS code. Some of them are RHC specific. It's going to tell you, can that be done on the same day as another medical visit, and does it pay the AIR, and are the deductible and coinsurance waived for that service? So this is a great document to go to. I've just done some screenshots of it, but alcohol screening and counseling is a separate visit.
On the tobacco, are there any visits? So on the tobacco one, I help do some.
And there, yeah, and there, yeah, and there are two different codes for the actual cessation, and it's the minutes are split. It's like up to 3 minutes, and then I don't know the descriptions off the top of my head, but yes.
So what I was wondering is, so if you do the screening, you find patients that are killing themselves with tobacco use, and then you want to bring them in.
Not in this area.
That's about 51% of patients have COPD. Black lung, it's not tobacco.
Yeah.
Yeah, where I was getting at is multiple patients in a therapeutic session for tobacco cessation.
So we can't do group sessions in an RHC because that definition of the encounter is a one-to-one between the patient and the provider. If you want it, the same thing with diabetes education doesn't qualify as an encounter. Group counseling doesn't count as an encounter because we get paid per patient with a provider, one-on-one, face-to-face. If you wanted to do some kind of group session, you would have to do that as a non-RHC service and probably do that in separate hours. Yeah. But just the opportunity, you have an area to pick up revenue and schedule your provider's resources a little bit more efficiently. Yes, ma'am.
I wanted to say that I know that CMS provides 8 sessions. So if you screen the patient for tobacco cessation and you discover that the patient, uses tobacco as some type of product, you have 8 different sessions that you can provide and bill for.
For the purpose of trying to.
For treatment.
Yes, okay.
Right. And so again, as long as we have a medically necessary face-to-face and there's not a limit on the number of times that code can be billed in a period of time, we have an encounter. But if the provider is feeling rushed and they're feeling like they're having to educate on smoking cessation at a regular E&M for a respiratory illness, then we can bring that patient back and spend the time we need to with that patient and get another separately billable standalone service. So I think this is something we need to make sure everybody is knowledgeable about. I think we miss an opportunity to serve our patients by not fully doing the preventive services. Yes, sir?
Preventive codes, they are not included in the AIR, right?
They pay the AIR when done alone.
Okay. If you just put a preventive code, still they can put it, pay as the AIR. You don't have to just get it at the end of the year for cost reporting.
You still have to report preventive services on cost report as far as break those services out. But that's what this chart will tell you. The 4th column there says, does it pay at the AIR? And if that service, when done alone, pays at the AIR, it's on that chart with a yes in that column.
And thereby gets included in your unduplicated census count for purposes of this account.
Well said. Well said. Okay. And then I'm going to kind of transition from preventive to wellness. We have been trying to work at the national level to get wellness services considered to be preventive services. So far we haven't, but I think with some of the initiatives we're seeing right now, we will see that. So this is an example. If I do my Welcome to Medicare IPPE exam, it pays at my full rate. The Welcome to Medicare is a one-time exam that we do to bring the patient into the Medicare program. And it has defined components of that exam. It is a physical exam. And it pays at our AIR. There is no such thing as a routine visit with Medicare other than these defined preventive services. So if your physicians and your non-physician providers are having people come back in for annual checkups, yearly physicals, that is not not and has never been a Medicare benefit. So only the preventive services. Other than that, we have to have a problem visit. So we don't want that chief complaint to say yearly checkup. Because Medicare doesn't pay for routine physicals. They pay for approved preventive services that have specific definitions. So I know it sounds like I'm being fussy. Those of you who know me know that I get in the weeds pretty quick. So annual wellness visit is not a routine physical exam either, and for Medicare includes no physical exam. And yet in the RHC, the provider must still have a face-to-face with that provider because we are getting paid that, what? All-inclusive rate. Anytime we get paid the all-inclusive rate, face-to-face with the provider. That doesn't mean that ancillary staff can't do some of the annual wellness visit screenings, but anything that we get paid our rate for, it has to include our provider. The fee-for-service rules for annual wellness visits are not the same as the RHC rules for annual wellness visits. My Blue Cross annual wellness has a physical exam. My Blue Cross annual wellness has 6 labs that they do, or 7 labs. I get a CBC, I get a metabolic panel, I get a lipid panel. That's part of my commercial wellness. No labs are included in the Medicare wellness exam. That's hard for patients because they want to come to the doctor and be touched. And that's hard for our providers because they have a patient in the room and they want to check them out. So make sure your providers are selecting those codes correctly and they don't have their own seat of the pants idea of what all wellnesses are, because it's not the same for commercial and Medicare. So again, if we do the annual wellness visit, back to your question, if we do the annual wellness visit when the patient is also there for their hypertension, we only get paid once. And so if they're there for annual wellness and they bring up another problem, it's just like we do with our kids' EPSDT visits. They're there for a screening, but they have a problem. We're going to switch that appointment to a problem visit and reschedule that wellness. Or we're going to see them for the wellness and we're going to reschedule the sick visit. So if we want to maximize our reimbursement. Now, if the patient never comes in and this is the only time we have the patient before us, we're going to do whatever we need to do. But our main thing is I see providers select the annual wellness visit code and they didn't do the service as defined by Medicare. They usually do more than that, more than what is required. If we were to have a Medicare women's wellness, it would look like this. If we did it all at the same time, if we did the annual wellness, subsequent visit, and we did breast pelvic screening, and we did the pap smear collection, it would look like this. However, we can do the annual wellness and the breast pelvic in 2 different visits and get paid twice. So again, you don't want your providers to get bottlenecked in the back because they think the patient's coming in for an annual wellness and then, bam, we have 6 other things that we need to address. But then we don't want to string the patient along if we know we never see Mr. Jones. He's hard to get here once every 6 months anyway. Then we want to take care of him. So Mendel did a good job on care management this morning. This is how we bill care management. G0511 is an RHC specific code for care management and for behavioral health integration. It's the same code. And it pays $67 and, whoops, this slide has not been updated. I am so sorry. I copied a bad slide. The price that he gave you this morning is correct. It's $76.25. My apologies. Yeah. Okay. My apologies for this slide not being updated. I did these on the plane yesterday. I'm so sorry. G0511 pays a consolidated fee schedule amount. It's good for chronic care management, principal care management, and integrated behavioral health management. And so the reason that the reimbursement amount changed this year is because they added principal care management and they blended those dollar amounts. So, we want to. The copay is not waived. And that, I'm glad you asked that. So there is a cost share for care management. And the patient must be made aware of that coinsurance amount before they enroll in the program. That's why we want to get care management and preventive services. Preventive services, it's already waived, but we would like to see care management in that bucket so that there's no cost share to the patient. Some vendors will tell you incorrectly that the coinsurance can be waived, and it cannot. If you make a reasonable effort to collect, those amounts may be able to go on your bad debt on your cost report, but we can't waive them up front. We can't waive any coinsurance and deductible. That is offering a kickback to our patients, and that is in violation of any of our conditions of participation agreements. So, we can only waive deductible and copay when it's a approved preventive service. And I don't think I said this before, but you do know that our coinsurance in a rural health clinic is 20% of the charges. It's 20% of the charges. And so if my office visit is $200 and my patient doesn't have a secondary, they owe me $40 for that visit. So we can't talk about price setting or fee schedule setting strategies. We have to be very careful about that for antitrust reasons. But be careful when you're setting your fee schedule that you realize you're not just writing off a contractual like fee for service. Your patient's out of pocket is going to be based on the amount of those services. And you can if you're not an RHC and you become an RHC, let me tell you, little Miss Granny Smith is going to realize that she used to pay you $8 and now she pays you $24. And she's going to ask why. Because you just took away her beauty shop money. So we need to be careful. You know, back in the day when we did 4 times Medicare fee schedule or 5 times Medicare fee schedule, and we said, oh, we'll just write the difference off. For it actually impacts our patient's back pocket in a rural health clinic. So you want those prices to be above your highest paying commercial, enough that you're not leaving money on the table for the commercial, but that you're not overcharging your Medicare patients. Sometimes, rarely, but sometimes we will have an office visit on the same day when it's time to bill CCM again. Sometimes that happens. When that happens, this is an example of that. The office visit is going to go in with the CG modifier. The CCM for that month is going to go on a separate line. Nothing is going to roll up, and we're going to get paid the all-inclusive rate for the CG line. We're going to get paid the fee schedule amount for care management. So sometimes people will roll it up, and that won't work. So, yeah. Oh, gosh, I got 10 minutes, and I'm not even halfway done. Medicare split billing. Anybody have a problem with that? Need an explanation of Medicare split billing? So what we get paid for in our all-inclusive rate is our provider's professional services. We are not paid for any technical components or technical services. So those are split out. And for an independent clinic, those charges are billed to Part B. And for a provider-based RHC, those are billed to the parent hospital, just as if that service happened at the hospital. Sometimes we have problems for, how many are provider-based? Provider-based, provider-based, both. So sometimes we have a problem where our clinics are on a different system than our parent hospital. Our clinic's on eClinicalWorks or EMDs, and our hospital is on CPSI, bless our hearts. And we can't get those charges to cross over, and so we have a workflow issue on that. So this is another really handy chart, probably one of the things that we're asked to give out more than anything, which says which services go on which claim form with which numbers. And so if you want a copy of that chart, I'll be more than glad to give that to you. One of the biggest problems we see, are we required to do some point of care testing in our clinics? And the most common thing we see is people don't know that those 6 required tests are still separately billable. Some people think that they're in their rate, their all-inclusive rate, and they are not. So if we accidentally roll up that UA into that office visit on the UB, what's going to happen with that? What now? Yes, we're going to lose the money for that UA. We also are going to overcharge our patient because that amount for lab is going to be on our CG line that calculates coinsurance, and there is no coinsurance on Medicare labs. So we are going to overcharge our patient, and we're going to miss out on that separate reimbursement. And so I almost think they're both the same. They're both equally a bad thing to do, because then we actually owe that.
The patient and you.
Yes, and then we have a compliance issue because we've overcharged the patient, and so technically we should refund that amount of the coinsurance to the patient. But that's the biggest problem we see. Also, if you're sending lab to a send-out lab, that lab bills Medicare for your patient. You should not be being back billed by outside labs, except for self-pay labs. Pass-through billing is not a good thing. Lab companies will still offer you that. Hey, we're going to only charge you $2.50 per CBC, but we want you to bill it. If we didn't perform the test, we can't bill it. The exception are inpatient labs, which we can, because inpatient reimbursement is different. And then again, if our self-pay patients, the lab won't take a self-pay patient. But our Medicare patients and our major commercials will not let us do pass-through billing. Oh man, drug screening is a hot mess. Yeah, it's a hot mess. But the rule is whoever performed the test bills the test. Now, if the drug screens are with an employer contract or something and we can do them on a set amount, but we can't bill a payer for something we did not perform. Yeah, we can't. Yeah. Yeah. And so LabCorp or Quest can't be giving me a cut on CBCs, but then I'm billing them to Blue Cross and making $4 on it. Yeah. There's no markup on lab services. Yes, ma'am.
What about send out pathology? For instance, can we bill for the collection fee?
You can do the collection for the PAP.
And then
They would bill for the PAP. So there are some pathology codes that only certain qualifying lab types can bill for. So we couldn't bill for performing a PAP anyway, because we're probably going to have a CLIA-waived certificate or maybe a moderately complex certificate and to bill for those pathology, you have to be a full-blown reference lab. Yeah. Okay. Gosh, I got 6 minutes. Immunizations, flu, pneumococcal, and COVID go on your cost report. We never drop them on the claim. We don't even put them on the claim at a $0 amount. They don't go on our claim at all for Medicare. flu, pneumo, COVID injections and infusions do not go on claims, and they are not separately billed to Part B, ever, ever, ever. We get cost-based reimbursement for those on the cost report, so we have those logs we have to keep up with. We have to give to our cost report preparer. Hep B and tetanus can go on our RHC claim if the tetanus is for an injury, not just a routine tetanus. Not that I'm 12 years and I need a new tetanus, but it doesn't pay separately. All other adult immunizations for Medicare are Part D pharmacy benefits. You will not get paid for them. We go into clinics all the time and they are stocking very expensive adult immunizations that they're not getting paid for. If you're using a third-party biller for vaccines like Transact, and there's another new one, talk to your cost report preparer about there because there can be some commingling issues with using that third-party pharmacy biller. Okay. Oh gosh, I got 4 minutes, Beth. I got 13 more slides. Are we good on telehealth as it stands right now with G2025? Is everybody good on that? That's going away when the public health emergency ends. And we will not be able to do we are statutorily prohibited from doing distant site telehealth for medical reasons, with an exception for the public health emergency. Look at this slide when you get the slides. Make sure you know the difference between originating site and distant site. They almost sound backwards. Originating is where the patient is, distance is where the provider is. And that's going to be really important as the public health emergency ends. Great MedLearn Matters article that was just updated. Okay. Our big win in the physician fee schedule is our mental health distant site telehealth is now payable at our rate. On May the 5th, they changed the directions on how to do that. So now it needs the CG modifier on it and either the FQ or 95 modifier to show whether it's audio-visual, two-way, or just audio only. So now you need at least 2 modifiers on those claims, the CG as of May 5th, and telling which way. Your revenue code for mental health is going to be 900, rev code 900 for mental health, telehealth, and it's going to have to be one of these codes, mental health codes, on the QVL. We didn't anticipate this. We thought an E&M was going to be able to go with this, but it's not. Right now we're limited to these 6 mental health. Like I said, that MedLearn Matters was just updated earlier in May. Hospice. This is another big win for us. If your RHC provider is also the attending hospice provider, so when the patient enters the hospice program, there is an attending assigned to them. If that is one of your rural health clinic providers, you can now bill those hospice services as an RHC encounter and get your all-inclusive rate. So in our small communities, everybody wears a lot of hats, right? And your medical director at your clinic may also be the hospice medical director. So those are going to be a CG modifier with the appropriate revenue code and the new GV modifier. But your provider has to be the provider on record with the hospice program. If we treat a hospice patient for a non-hospice visit, an injury usually, we have to have a 07 condition code on that claim. We have to have the GW modifier. And the hospice diagnosis can't be on the claim at all. So if your EHR is one that pulls everything over and dumps it in the assessment section, that lung cancer can't be on that claim, just the sprained ankle. Okay. And here's a whole MedLearn Matters about it. Another win for us is we can bill more than one care management service in a 30-day period now. So TCM and CCM can be billed in the same month now by our RHC. Okay, 2 o'clock, how about that? Questions, comments? I know I blew through the last little bit of it. Good discussion, though. Yes, ma'am.
I know that you mentioned earlier that if we have a clinic visit and a specialty visit in the same day, we can't bill for both.
You won't get paid for both.
Don't get paid for both. But let's say for best practice, for the best care of the patient, there's limited resources for traveling. We go ahead and allow the specialty to do a procedure even though they were scheduled with the provider. As far as from a billing perspective, do we put that whole visit under that specialty provider for Medicare, or do we actually, since it's two providers involved, I know what I mean.
Yeah, so it's field locator 76 where you put the rendering physician. There are other optional fields under 76. I don't know exactly how they're numbered, so you could list both providers on there. Your bigger issue is going to be how are you going to attribute that service to those providers. But yes, if they saw primary care with an E&M and then they say they saw dermatology for,
Well, I'll give you an example.
yeah,
Primary care visit noted to have an ingrown toenail. General surgeon was in the building, was able to address that
okay.
and take care of that.
Yeah, so I would put the E&M and the procedure code on there because we do have a separately identifiable procedure. And then I would, whoever goes in 76 as the attending, but there is a field under there where you can add more than one provider. Yeah, I don't know a good answer for that. You know, that's part of us trying to figure out how to integrate specialists into the RHC. But I will say this, your specialists need to be billing as RHC providers. The day is long gone where somebody comes in and rents a room at the end of the hall for a day. That is not best practice for commingling issues. But good question. Yes, sir.
Not from a Medicare perspective, but from the Medicaid billing, the patients, those who come for the allergy injections like a couple of times a week, do you bill them as encounters or you cannot bill them as encounters?
So I'm not familiar specifically with Virginia Medicaid on that. I always say allergy shots are going to be the life and death of us all. So an injection-only visit doesn't always require the skill level of a qualified RHC provider. You know, if that's an established patient with us and they've been on that series for a while, if it's just a shot-only visit, it's not going to qualify as an encounter. Now, if that child is sick and you need to decide if they're well enough to get their allergy shot or something, and I'm not clinical, so if that falls apart, I'm sorry. Then if you have an evaluation and management, but it wouldn't normally be medically necessary to evaluate that patient every time they get an allergy shot. Although the nurse is going to give the allergy shot, you're going to have a nurse visit, they're going to wait the prescribed time to make sure they don't have a reaction. That cost of that nursing service is going in our allowable cost on our cost report, but we won't have a visit for it. So we indirectly get that cost attributed and it catches up in our rate calculation. But we usually charge nurse visits for Medicare and Medicaid and then adjust them off with a special adjustment category so we're keeping up with that utilization. If you felt like you did need to see that patient and it was more than a nurse visit, I would just make sure the documentation supports that it required a provider service.
But those patients, even if you don't see them each time, at least once a month or so, you should evaluate them to see what's the progress of allergy injection.
That's true. And then we would be,
That could be the encounter.
yes, sir. Yeah. Then you would be evaluating them again to manage their allergies. Then it'd be the same reason why we don't put follow-up on hypertension. We put hypertension because we're really making sure, hey, you know, is that lisinopril working or do we need to switch them to the Medicare or whatever else? Those are the two I know. These are the two at our house. Lisinopril gave me that nasty cough, so I don't do that. The main thing you need to know about this slide is my email and my phone number. You may reach out to me as a follow-up to this conference at no charge to you. If I can answer a question, point you in the right direction, or give you some more information as a follow-up to this, we will always do that. All right, thank you very much.